Welcome everyone. In this presentation, we will focus on ocular artifacts in EEG, why they occur, how they appear on the tracing, and how we can avoid mistaking them for true cerebral abnormalities. The central goal is practical pattern recognition. We will connect eye behavior, montage distribution, patient state, and EEG morphology so interpretation becomes safer, clearer, and more confident. Next slide, please. This visual map gives us the whole framework before we examine each pattern in detail. Ocular artifacts are not simply random noise. They are physiologic signals generated by eye movement, eyelid activity, and retinal responses. Once we understand the mechanism, the individual patterns become much easier to recognize and less likely to be overcalled as pathology. Next slide, please. The practical risk with ocular artifacts is misinterpretation. A frontal slow wave, a rhythmic run, or a sharp transient can look concerning when viewed in isolation. But EEG interpretation should not rely on morphology alone. We need to ask where the field is strongest, whether the pattern moves with the eyes, what state the patient is in, and whether video or technologist notes support an ocular origin. Next slide, please. The key mechanism is the moving corneal retinal dipole. The eye is not electrically silent. The cornea is relatively positive and the retina is relatively negative. So when the eyes move, this electrical field moves as well and can appear in the EEG. This explains why ocular artifacts are usually strongest near the orbits, frontal poles, and anterior electrodes. Bell phenomenon is especially important because during eyelid closure, the eyes deviate upward, producing a characteristic frontal effect. Next slide, please. The main ocular artifact patterns can be grouped into a few practical families. Blink and eyelid flutter are mainly related to vertical eye movements. Lateral gaze and slow roving eye movements reflect horizontal or lateral eye movement. Lateral rectus spikes and electroretinogram responses are important mimics because they can create sharp or time-locked patterns that resemble cerebral activity. Classifying the artifact family first makes interpretation much more systematic. Next slide, please. Blink artifact is one of the most common ocular patterns and one of the most useful to recognize confidently. It is typically bifrontal, synchronous, and diphasic. The most important discriminator is the field. It is strongest anteriorly and usually does not extend convincingly into central leads. When the EEG pattern coincides with a visible blink or technologist notation, the interpretation becomes much more secure. Next slide, please. Eye flutter can be more deceptive than a single blink because it produces repetitive rhythmic frontal activity. In some cases, periocular muscle activity adds faster components, making the pattern resemble bifrontal spike and wave or rhythmic delta activity. The key is to check whether the activity is frontally dominant, whether it is state-dependent, and whether it is time-locked to visible eyelid movement. Next slide, please. Lateral gaze is recognized by its horizontal dipole. In bipolar montages, one of the most useful clues is opposite polarity across the left and right frontal temporal regions, especially around F7 and F8. During drowsiness, slow roving eye movements may produce very slow, low-amplitude activity that can look like baseline instability. However, this activity is not random. It has a characteristic frontal temporal distribution and often accompanies drowsiness. Next slide, please. Lateral rectus spikes are classic mimics of anterior temporal epileptiform activity. They are brief motor unit potentials and can look sharp and stereotyped. The protective strategy is to look for the accompanying lateral eye movement slow wave, the location at F7 or F8, and the low amplitude of the transient. REM eye movements create another state-specific ocular pattern, usually recognized in the context of sleep staging and characteristic lateral eye movement waves. Next slide, please. During photic stimulation, not every time-locked frontal response is cerebral. The electroretinogram is a retinal response that may be recorded at the frontal poles. It is usually low amplitude, monomorphic, and maximal at FP1 and FP2. One practical confirmation maneuver is covering one eye during stimulation. If the ipsilateral frontal polar response diminishes, that supports a retinal rather than cerebral origin. Next slide, please. When distinguishing ocular artifact from delta activity, the field is the key discriminator. Cerebral delta activity usually has a distribution that is not confined only to the orbitofrontal region. Ocular artifact tends to fall off quickly posteriorly and may show a phase reversal when supraorbital and infraorbital channels are available. Correlation with blink, eye opening, eye closure, or technologist notes adds important confirmation. Next slide, please. Sharpness alone is not enough to diagnose epileptiform activity. Ocular flutter with periocular EMG may resemble spike and wave, and lateral rectus spikes may resemble anterior temporal interictal epileptiform discharges. The decision should be based on field, repetition, state, and the relationship to eye movement. True interictal discharges usually have a broader field and may persist into stage 2 non-REM sleep, whereas many ocular mimics remain tied to eye behavior and light drowsiness. Next slide, please. This checklist is a practical safety screen before labeling a pattern abnormal. Ask whether the field is strongest frontally or orbitally. Look for symmetry or opposite polarity suggesting eye movement. Consider whether the event occurs during blinking, gaze shift, drowsiness, REM sleep, or photic stimulation. Then check for absence of central extension and confirm whether patient behavior or technologist notes support an ocular origin. Next slide, please. A simple workflow helps turn these details into a reliable reading habit. Start with the mechanism. Is this likely a moving ocular dipole or periocular muscle activity? Then, name the pattern, inspect the field, check the state, and only then make the interpretive decision. When uncertainty remains, review alternate montages, inspect video or technologist notes, and avoid premature diagnostic labeling. Next slide, please. The main message is that ocular artifacts are predictable when mechanism, field, and state are interpreted together. They are usually frontally dominant, state-dependent, and linked to eye movement. Accurate EEG interpretation depends on integrating waveform appearance with behavior, montage, patient state, and technologist observations. This presentation was chosen from Professor Mohammadi's educational archive. Thank you for watching.